Our next speaker is Dr. Santosh Patel. Topic: Nucleus drop, mishandling the storm.
Harshvardhan.
Good afternoon, respected dignitaries on the dais and off to the dais. Today's my presentation on the nucleus drop management, no financial interest. Given the variety of the pathology presented by the human eyes, even the best surgeon have some complications. Despite the application of the vigilant manure, PCR still occurs at the rate of between 0.45% to 14.7% depends on the experience. Retained lens fragment is estimated 0.3% to 1.1%. So aim up to that presentation to minimize the risk of complication and to manage the optimally complications that do occur during the cataract surgery. Conditions that put patient at risk for the dropped nucleus are posterior capsule could get injured by the anterior intravitreal injections. This is most commonly performed procedure in the ophthalmology. Posterior polar cataract have a high incidence of posterior capsular rent formation, rupturing the posterior capsule during the chopping and cracking, and most commonly hydro rupture of the posterior capsule during the hydrodissection with pupil snap sign. There are two stages of the dropped nucleus. Dropping nucleus and dropped nucleus recognizes the tilting nucleus away from the anatomical position to slide backward into the vitreous cavity. If this dropping is recognized, you can manage with the 23 or 5G needle can be inserted via the pars plana, aiming to go behind the nucleus and lens elevated to forward into the anterior chamber and can be removed by the vectis. And care has to be taken for the vitreous traction. If the nucleus has already dropped to the retina, a vitreoretinal surgeon is required. Management of the dropped nucleus. It is important to preserve as much as of anterior capsule as possible so you can still implant IOL over the anterior capsule. Focuses on the cleaning of residual cortical matter and doing the best anterior vitrectomy possible. In a stressed state of mind, do not chase the nucleus, do not try to retrieve it, and do not deny that the complication has occurred. So if the surgeon has not feel comfortable handling the cortical metal, better to stop. For the drop nucleus without using the fragmentome, perform the vitrectomy with the 23G vitrectomy system, and after PVD induction, use PFCL for the protection of the posterior pole to aspirate the nucleus by using a 23G vitrectome and implant the IOL depends on the situation and remove the PFCL. So advantage of this technique, we can prevent the widening of the sclerotomy and minimize the risk of the retinal injury by preventing the intravitreal maneuver and decreasing the surgical time. But the limitation is hard cataract. We cannot remove the hard cataract with the vitrectome. And for the hard cataract, we can elevate the nucleus with the PFCL and remove from the anterior chamber. So with hard nucleus, you want to treat with inside the vitreous cavity. Then you need a fragmentome. After complete vitreous removal and all the tractions, do PVD so that you can use PFCL. And after that, enlarge the sclerotomy with the MVR blade for the fragmentome. And then use the fragmentome for the removal of the hard nucleus. So after completion of the vitrectomy, you can plan your IOL depends on the anterior capsule status. Same for the IOL drop also. So same vitrectomy and remove all the tractions and pick up the IOL with the forceps and remove from the anterior wound. So after after removal of this lens, you can proper clean up anterior cortex. Then you can plan retrofixed IOL as a IOL of choice without a capsular support, and you can close with the suture. So indication for the types of IOL, lack of the capsular support or lens replacement or exchange or dislocated lens, you need a scleral fixated IOL or the retrofixated IOL. But you have a good CCC, you can place a 3-piece IOL or sulcoflex IOL. So these are the photographs of the retrofixed IOLs. For the scleral fixation, you can fix 4-point fixation or single 1-point fixation. Here you can do 1-point fixation with without any knot and without any scleral fab. So you just plan IOL scleral fixed IOL as a normal routine and suturing the eyelets, and after that just give a 3 to 4 rows of the suture, both the end, without giving a knot. So for proper and equal and proper tension, and this flow per section is good for the SFR. Here you can see the post-op photographs of the 3 to 4 loops of the suture without a knot. So outcome, primary cause of the visual impairment in nucleus drop, so start macular edema, pre-existing ocular disease, corneal edema, retinal detachment, and the epiretinal membranes. And significant predictor of better visual acuity is better presenting visual acuity, presence of intraocular lens, no suprachoroidal, no choroidal, no RD, no CMA, no additional surgery. So there is no significant association with final visual outcome, and IOP outcome depends on the timing of the surgery, whether within a week or more than 12 weeks. For counseling, one of the most important thing for managing this patient to communicate with the patient. First in the operating room, second in the after the surgery, and third communicate with the patient till second surgery with the retina surgeon. So as a take-home message, early detection of the dropping nucleus you can prevent for the further surgery from the retina. In a state of mind, do not chase the nucleus and do not try to retrieve it. The best timing for the vitrectomy is possible, probably the same sitting as the cataract surgery, as this negates the need and cause for the repeat surgery. And timely and wisely management of the situation is vital for both patient and surgeons. Thank you.